The Lancet series on midwifery is a series of 4 papers looking using a different range of research methods at the strong evidence now that we know that underpins the importance of midwifery for mothers, for babies, for families, for communities in low and middle and high income countries across the world. We've looked at the impact it will have, we've looked at how it can save lives and help improve health and well-being, and we've looked at how to implement that in a health system. And so it can be used now by decision makers, whether those are policy makers, ministers of finance and health, or whether those are health professionals themselves, or indeed women themselves, in helping to develop health systems that will be effective and efficient and good for women and babies.
Every now and then something very special comes along, and this is an extremely special series. It's challenging, it's creative, and it's constructive.
This morning was very interesting. Particularly interesting was the framework for midwifery services, because it not only describes the different components of the services that are needed, but gives an idea of who can provide those different elements of the midwifery services and the importance of the midwife within that context.
When it comes to putting a program together and convincing governments and harnessing political will, the first question they always ask is, where's the evidence? And so even though we all had sort of pockets of excellence and we knew the solutions, the Lancet series is now harmonizing all that evidence for us and making sense of it and extrapolating it.
So we at WHO think this Lancet series in midwifery will make a significant difference, because it really focuses the attention on the quality of rights-based care from the perspective of women and newborns. And for the first time in decades, it provides the evidence that we need through a quality of care maternal newborn health framework that will enable donors and others to invest in strengthening the quality of midwifery services provided.
The job of the first paper in the series was really to set the scene. It was to start the analysis of existing evidence of what midwifery is, of how to describe it, and really to look at why it matters to women and to babies. And so we had to start by actually defining midwifery, which might sound strange, but because midwifery varies right across the world, some countries it's provided by midwives, some countries it's provided by a mix of nurses and doctors and community health workers. And so we actually had to describe midwifery as women and babies need it, and that was the very first step. So we did that. And then we went on to look at what components of care women and babies need. The whole focus of paper 1 was to look from the perspective of women and babies. Any mother, any baby across the world, what do they need? And we used a lot of existing evidence, hundreds of existing reviews and studies of women's views to characterise what would make a difference to women. And we established a framework. Now this framework is becoming, if you like, a stable basis for analysis, but it's also becoming a stable framework for how you might design a health system, or how you might educate students, or how you might monitor and assess how a health system is working. And it's got a number of elements to it. So if I just take a few minutes to describe it, the first sort of top element of the framework, if you like, is to stress that all women and infants need certain kinds of care. And then there's additional care that women with complications need. So that's not a low-risk, high-risk split. That is that all women need certain kinds of care and others need an additional set of care. Moving down the framework, the first line is about practice categories or interventions. What specific things, tasks do women need from the health system? All women need 3 different sets of things. They need education, information and health promotion. They need assessment, screening and care planning. And they need first-line care, the care that will keep them normal, that will prevent complications happening. So everybody needs that. Then women with complications need possibly 2 other things. One is first-line management of those complications, again to try and prevent them from getting worse. And then finally, they'll need specialist medical care if they have an emergency or a serious medical obstetric, or indeed neonatal problem if the baby is very sick. The rest of the framework takes through the way in which that should happen. So not just what should happen, but how it should happen and who should provide it. So the how it should happen in terms of organisation of care, for example, is that continuity really matters between where the woman and baby are, where the family is, and the facilities or hospitals that they might be using. So the community through to the facility. And also that those services are accessible and acceptable to the local community. There's then, if you like, the values set in which that care is given, so it's respectful, so it's tailored to women and babies and families' needs individually. There's then the philosophy of care, and really importantly, that's about really helping women to optimise their own strengths. So trying to promote normal processes, not interfering too soon, not interfering at all if in fact the mother can manage to give birth herself, to breastfeed herself without additional extra help, to strengthen women's own capabilities. And then the final element of the framework is the characteristics of the care providers. Obviously they need to be competent and skilled, but they also need a good skill mix integrated with other care providers across different professions. And they need to provide culturally sensitive care, so they're not just doing a one-size-fits-all. So that's the framework, and that framework is being taken by all the other papers to really help them analyse and understand other elements of care. What we then did was we used that framework for analysis, and we took out of the literature an understanding of all of the outcomes that midwifery would then improve. And we found an amazing 56 outcomes in the existing literature. And we've measured those and we've laid them all out. And they include saving lives, saving mothers' and babies' lives, preventing stillbirths through a number of clinical outcomes, but also looking at maternal infant attachment, at psychological outcomes, at social outcomes, and indeed at saving costs and reducing health service involvement. So it's very, very broad and very important that those outcomes can be improved. And finally in the paper we really looked at the literature around care by midwives and care by other people. And what we found was really important, that midwives practice the whole scope of midwifery, not surprisingly, and that other less skilled workers can do components of it, but that it's likely to be more fragmented and not so comprehensive and not so effective.
So I led paper 2 of the series, and essentially we took the framework that the first paper of the series developed, which was a framework for quality maternal and newborn care. We looked at the interventions that midwives and midwifery care can deliver, and we used an analysis called the LIST tool. So LIST is the Lives Saved tool. That's a pretty commonly used tool in this field, although not in this particular way before. We took 78 countries, the 78 poorest countries in the world, and broke them into 3 groups related to their Human Development Index, which is a measure of a country's status. So we had 26 countries in the lowest Human Development Index, 26 in the middle range, and 26 in the higher range. And then we modelled what an increased coverage of those interventions would be in those 3 different groups of countries, and showed that even a modest increase, so only 10% every 5 years out to 2025, makes a significant difference to lives saved. And the lives are the mothers' lives, the babies' lives, neonatal deaths and stillbirths. So as the coverage increased, so did the number of deaths decreased. So that was very reassuring that midwifery care, particularly the interventions delivered by midwives, makes a huge difference to changing a country and saving women's lives.
Paper 3 looks at the experience of a set of low-income countries that have been really successful in improving maternal health. And what we've learned is that it's really not enough to say that midwives have to rely on a well-functioning health system. What we should say is that a well-functioning health system is a prerequisite for midwives to be effective. The second thing that we found is that you get such well-functioning health systems in countries that are committed to move towards universal coverage. And the third thing is that quality is important, and quality is often neglected, and that if you want to improve quality, you have to think about what the demand of women is for good quality care.
So the great thing about this story being now available in the Lancet is this: in this fourth paper, we bring all the threads together, and they can really help set up, develop, strengthen midwifery services in the countries. It also talks about value for money, how investing in midwives pays back not only in less caesarean sections, but also in deaths avoided and other interventions avoided. And it talks about how this contributes to all the big plans there are for newborn and for maternal health and for child health and for family planning, and how that all comes together in the big global agenda that is going to go forward post-2015.
Our paper engages with the reciprocal relationship between midwifery and human rights on the basis that if we get human rights right, it'll be easier to enact midwifery, and vice versa. If we enact midwifery, as a consequence, we'll increase human rights for women and families. And by increasing human rights, we both reduce maternal mortality and morbidity, but will also, and importantly, balance out the increase in interventions that are currently happening in maternity care, so that a human rights element to this will create that balance between those two phenomena, so that we get the best possible care for women and babies and families.
Our paper is the last paper of the series to come out, and we had to actually wait for the other papers to be published, because we are taking the findings from those papers and setting a research agenda. And that's essential because research takes time, it takes money, and there are limited resources and limited funders. So this is a way to summarize all the important research gaps from the papers in the series through a methodological process, identify the top 10 areas for future research in order to improve quality maternal and newborn care.